Bismillahirrahmanirrahim. The topic of our discussion today is Wilson disease. So, Wilson disease occurs as a result of excessive deposition of copper in the body. Unlike hemochromatosis, there is an excretory mechanism present for excretion of copper, but in this case, it is ineffective. So, there is an increased deposition of copper in the body, which is accumulated in liver, brain, eyes, kidneys, and inside the bones and joints. This excessive iron results in tissue damage in the respective organ, resulting in Wilson disease. Before moving on to pathogenesis, we must understand the normal metabolism of copper. So almost 40 to 60% of dietary copper is absorbed from the duodenum and proximal small intestine. This absorbed copper is transported through portal blood into the liver. Inside the blood, copper is loosely attached to albumin and histidine amino acid. Once the copper is delivered to the liver, it is incorporated into an alpha-2 globulin protein known as ceruloplasmin. The incorporated copper is delivered to other cells through the blood, and the copper is attached to ceruloplasmin. Almost 90 to 95% of copper in the blood is attached to ceruloplasmin, whereas 5 to 10% is in free form, or it is loosely attached to albumin. This copper is delivered to various tissues, and the excessive copper and ceruloplasmin is taken up by the liver and degraded by lysosomes. The excessive copper left is incorporated into bile and it is excreted from the body. Primary culprit in the pathogenesis of Wilson disease is mutation in ATP7B gene. This ATP7B gene is present on chromosome number 13, and it encodes for a specific protein known as ATP7B protein, which is a part of transmembrane copper transporting ATPase protein. This transmembrane copper transporting ATPase protein is present on the surface of cells, mostly hepatocytes, and it binds the copper to ceruloplasmin. So mutation in ATP7B gene results in defective formation of transmembrane copper transporting ATPase protein, which leads to decreased incorporation of copper in the ceruloplasmin. Moreover, it decreases the secretion of ceruloplasmin itself, and there is decreased copper excretion in the bile. So all these factors ultimately lead to increased copper levels in the blood. This excessive copper is deposited in various organs, resulting in tissue damage. The increased copper in the blood, once it is deposited in different organs, it damages the cells. First of all, through increased production of reactive oxygen species. There is an increased production of reactive oxygen species by a specific reaction known as Fenton reaction. Fenton reaction means production of reactive oxygen species in the presence of a catalyst. Copper acts as a catalyst in this case. These reactive oxygen species damage the cell membrane and cell organelles, resulting in cell injury. Moreover, copper also binds to sulfhydryl groups of various proteins. These proteins are performing important functions in the body, resulting in dysfunction of these proteins. Hence, the cell is incapable of performing its routine functions, which also leads to cell death. Copper also displaces the metals from certain metalloenzymes, hence making them unfit, resulting in cell injury and ultimately cell death. The histological picture reveals ballooning of the hepatocytes. Ballooning means swelling, and moreover there is steatosis as well. Steatosis means increased lipid deposition. The histological picture of Wilson disease affecting the liver resembles non-alcoholic fatty liver disease or NASH. For one thing, the hepatocytes are ballooned, which ultimately result in necrosis. The hepatocytes have lipid deposition, which is known as steatosis. And moreover, hepatocytes also possess amorphous eosinophilic bodies known as Mallory-Dunk bodies. These Mallory-Dunk bodies are also present in alcoholic liver disease and non-alcoholic fatty liver disease. These Mallory-Dunk bodies are present in the swollen hepatocytes, which are near to necrosis. There are focal areas of mild to moderate necrosis. Copper deposition inside the hepatocytes can be demonstrated by two stains. The first is rhodamine stain, which demonstrates free copper, and the other is ornithine stain, which demonstrates copper binding proteins. The dry weight of copper in the hepatocytes is usually more than 250 micrograms in Wilson disease. Moreover, there might also be liver cirrhosis in the later stages of the disease, which is characterized by interstitial fibrosis and shrinking of liver. Copper deposits inside the brain are mostly in the putamen and basal ganglia, which result in the atrophy of these areas, and in certain cases, cavitation of these areas might also be present. Copper deposits in the eye result in the formation of specific ring-like structures known as Kayser-Fleischer rings. These Kayser-Fleischer rings are greenish or brown in color, and they encircle the cornea, which can be seen on the examination. Wilson disease can be abrupt or it can slowly progress into a clinical disease. The age of onset varies from 6 to 40 years, and average age of onset is 11.4 years. The disease is autosomal recessive. The presenting signs could be due to a liver disease, which can manifest as nausea, vomiting, loss of appetite, and right hypochondrial pain might also be present, along with jaundice. Copper deposits in the brain result in certain neurological disorders, which resemble a Parkinson-like disease. The disease is characterized by presence of tremors, poor coordination, chorea, rigid dystonia, which means the rigidity of the muscles, and there is loss of tone. Moreover, gait disturbances might also be present. The Parkinson-like disease occurs due to deposits of copper inside the basal ganglia. Copper deposits in the cerebral cortex result in dementia. Moreover, certain psychiatric disorders might also be present due to copper deposits, which are characterized by depression, phobias, and compulsive behavior. Since copper directly damages the cell membranes of the red blood cells, hemolysis is also present. Kayser-Fleischer rings means formation of a ring-like structure which is greenish or brownish in color around the cornea. These Kayser-Fleischer rings do not disturb the vision. The diagnosis is established by demonstration of increased copper inside the liver, increased urinary excretion of copper, and decreased plasma ceruloplasmin. Treatment is with penicillamine, which is a chelating agent, and it binds to free copper inside the blood and excretes it. Moreover, zinc is also given, which inhibits the absorption of copper by actively competing for it. Treatment in case of full-blown liver cirrhosis is liver transplant. So this brings us to the end of discussion about Wilson disease. If you have any questions, do let us know in the comment section. Thank you.